This is a review of the functions of the vascular and cardiac system. First, we go over the role of the sonographer. The role of the sonographer is to provide the highest quality exams. This includes real-time imaging of organs, soft tissue, and vessels. It also includes Doppler for vessels and their structures. The second role of the sonographer is to understand that exams are sonographer dependent. The exam is only as good as the sonographer, so the tech must recognize, demonstrate, and communicate anatomy and pathology to the physicians or provider. The cardiovascular system has three important functions, with one being transport, two being regulation, and three being immunity. Transport is divided into two, with the first being the arterial system, whose primary function is to deliver nutrients in the blood that are carried to each cell in the body. The nutrients that are delivered include oxygen, glucose, amino acids, electrolytes, and hormones. The cardiovascular system delivers oxygen and nutrients into organs for absorption. Due to its central role in processing absorbed oxygen and nutrients, the liver is affected the most. Now, the venous system's primary function is to remove products to be carried away from the system, and these waste products include carbon dioxide and urea. The regulation function of the cardiovascular system is essential for thermal regulation and controls body temperature. The cardiovascular system also has a function of immunity. This is proteins that are carried away by the cardiovascular system, and this is necessary for the resistance and elimination of disease. Reviewing again the functions of the cardiovascular system, with number one being the transport of nutrients through the arterial system. So primary function is to deliver nutrients in the blood that are carried to each cell in the body. Those nutrients would be electrolytes, hormones, oxygen, glucose, and amino acids. The transport function through the venous system is to remove waste products to be carried away from the system, and those waste products would be carbon dioxide and urea. The regulation function of the cardiovascular system is essential for thermal regulation, and it controls body temperature. And third, the immunity function of the cardiovascular system is for proteins to be carried away by the cardiovascular system, which are necessary for the resistance and elimination of the disease. Now we're getting into the anatomy of the heart, so the size, shape, and location of the heart. The heart is a cone-shaped organ. It's roughly the size of a closed fist. It lies between the lungs, posterior to the sternum, so right behind the sternum. The greater portion lies slightly to the left of the midline, so the heart is not directly in the center of the chest. It's slightly to the left of the middle portion of your chest. The shape of the heart is towards the bottom. It has an apex shape. It's a pointed end of the heart that holds the ventricles of the heart. The base is the top broader portion of the heart that holds the atrium, or atria for plural, located towards the top of the organ. Into the walls of the pericardium. Another name for the pericardium is the pericardial sac. The sac that covers the heart and holds fluid to keep the heart cool. It also cuts down on friction of the heart walls. The pericardial sac consists of two layers: the fibrous outer layer, which keeps the heart in place and is attached to blood vessels, the sternum, and the diaphragm, and the serous inner layer, which is continuous with the epicardium. This serous inner layer produces lubricating fluid called pericardial fluid, which allows the heart to beat smoothly without friction. The third part of the wall of the pericardium is the pericardial cavity, and this is the space between the serous layer and the epicardium. Again, the epicardium is the outside layer of the heart. The pericardial cavity holds serous fluid and it prevents friction as the heart moves. And we're reviewing the heart wall, so the walls of the pericardium. So the layers of the heart wall are the pericardium, which is the pericardial sac, the parietal layer, and the pericardial cavity. So I'm going to explain more in depth. The pericardium, which is the pericardial sac, that's again the fibrous and serous layers that enclose the heart. The parietal layer is the part of the serous pericardium which lines the fibrous pericardium. And the pericardial cavity is the fluid-filled space in between. Now we're getting into the layers of the heart. Layers of the heart wall consist of the epicardium, the myocardium, and the endocardium. So the epicardium is the thin outside layer of the heart. The myocardium is the middle muscle layer. It's made of cardiac muscle and it's responsible for the heart's contractions. Myo means muscle. The endocardium is the thin inner layer that lines the chambers of the heart. Chambers. The heart is divided into 4 different chambers. The top 2 are the 2 atria, which are the receiving chambers. The right atrium receives blood from all parts of the body except the lungs. The right atrium is also slightly larger than the left atrium, and it receives blood from the superior vena cava and the inferior vena cava, as well as the coronary sinus. The left atrium receives blood from the lungs and from 4 pulmonary veins. So the 2 atria, which are again the receiving chambers of the heart, are separated by the interatrial septum. The interatrial septum is located between the right and left atria. The septum closes at birth and it's usually open during development in the uterus. The opening is called the foramen ovale. The bottom 2 heart chambers of the heart are called the 2 ventricles. These are the exiting chambers. The right ventricle pumps blood into the pulmonary artery, which is also called the pulmonary trunk. The pulmonary artery bifurcates into the right and left pulmonary arteries. The pulmonary trunk, or the pulmonary artery, carries deoxygenated blood to the lungs. The left ventricle has the thickest wall and it receives blood from the left atrium. Blood exits the left atrium through the aortic valve. So blood flows down from the left atrium through the bicuspid valve, which is also known as the mitral valve, and is pumped out through the aortic valve into the ascending aorta. The 2 ventricles are separated by the coronary sulcus. This is also known as the interventricular sulcus. The coronary sulcus separates the atria from the ventricles, so it goes horizontally across the heart. The anterior and posterior interventricular sulcus separates the right and left ventricles externally, and the anterior ventricular septum separates the right and left ventricles internally. Now we get to the blood flow through the heart. Blood flows through the heart beginning at the right atrium. It receives blood from the IVC and the SVC, which then flows through the tricuspid valve into the right ventricle. The deoxygenated blood flows through the pulmonary valve. This is also known as a semilunar valve, through the pulmonary artery. The deoxygenated blood flows out of the heart into the lungs for purification and oxygenation. Blood returns from the lungs to the heart through the pulmonary veins, and it is now oxygenated blood. The left atrium receives the blood, and it flows through the mitral valve to the left ventricle. From the left ventricle, blood flows through the aortic valve into the ascending aorta. Valves. Heart valves allow blood to flow in one direction through the heart chambers, which prevents backflow of blood. There are two types: the atrioventricular valves, which would be the tricuspid valve and the bicuspid valve. The bicuspid valve is also known as the mitral valve. And the semilunar valves, which would be the pulmonary valve and the aortic valve. Viewing the heart valves again, the atrioventricular valves are valves that connect the heart's atria to its ventricles. The tricuspid valve is one of the atrioventricular valves, and it's located between the right atria and the right ventricle. The mitral valve, also known as the bicuspid valve, is the other atrioventricular valve, and it's located between the left atria and the left ventricle. The semilunar valves guard the base of the two large vessels leaving the ventricular chambers. So the first one would be the pulmonary valve, which is the heart valve that allows blood flow from the heart to the lungs. The aortic valve is the heart valve that controls flow of oxygen-rich blood from the heart to the aorta. So there are many different types of blood vessels, and blood vessels are the network of tubes that carry blood away from the heart, transport it to the tissues of the body, and then return it to the heart. Arteries carry oxygenated blood away from the heart. So if you remember, arteries away, AA. Veins carry deoxygenated blood towards the heart. Blood vessels are a transport system consisting of several different types of vessels, including arteries, arterioles, capillaries, venules, and veins, which further connect through perforators and deep veins. Arteries are vessels that carry blood away from the heart tissues into the large arteries. They leave these large arteries and branch into medium-sized arteries, which then in turn get smaller and are called arterioles. Arterioles begin to go into the capillary beds. Through these small vessels, osmosis, nutrients, gases, and exchange of stuff within the capillaries themselves occurs. Arterioles connect to the arterioles. Once the vessels reach the bed, they are now referred to as arterioles, which then connect to arterioles. The arterioles are coming into the capillary bed, which then connect directly to the venules. The venules go into the small veins, which then go into the superficial venous system, which travels through the perforators and into the deep venous system. The veins, venules, go into the small vein, which go into the superficial venous system. And the perforators are vessels that travel across and act as rungs on a ladder through which the superficial blood flows to the deep venous system. And the deep veins bring blood back to the heart. This is just a schematic of the blood vessel anatomy coming out of the heart, the arteries breaking down smaller and smaller, different types of arteries, down to the arterioles and capillaries, which meet with the venules, veins, then to the vena cava, and back to the heart. Blood vessels have three walls or three coats. Blood vessels have three coats or layers. Arteries and veins have a hollow opening called a lumen through which blood flows. Arteries are thicker and stronger than veins and deal with the pulsation of the heart. Both veins and arteries are made up of several layers. The layers are the tunica intima, the tunica media, and the tunica externa. The walls of the blood vessels are supplied by the vasa vasorum. So the walls of the blood vessel have three layers: the tunica intima, the tunica media, and the tunica externa or adventitia. The tunica intima is the innermost layer, which is a single thin layer of endothelium which lines the lumen or the interior of the vessel. The tunica media is the middle layer, and this consists of the elastin fibers and smooth muscle. This is also the thickest layer. The tunica externa, or the tunica adventitia, is the outermost layer and is mostly composed of connective tissue. It supports and protects the vessel. And the vasa vasorum is the blood vessel that feeds the exterior walls of the tunica adventitia. Blood circulation. Blood circulates through 5 different systems. The pulmonary circulation refers to the lungs, so pulmonary lungs. Deoxygenated blood flows from the heart's right ventricle to the lungs, and oxygenated blood returns from the lungs back to the heart. The pulmonary trunk bifurcates to form the right and the left pulmonary arteries, and those enter the lungs on either side. The pulmonary veins, there are 2 veins per lung, so 4 total. The blood exits the lungs, enters through the heart's pulmonary veins, and then flows into the left atrium. Then the digestive circulation. This digestive refers to the gut. The mesenteric circulation, supplying the digestive tract, absorbs nutrients from the small and large intestines into the venules, which then converge into the SMV, or the superior mesenteric vein. The SMV then leads to the portal vein, directing blood from the intestines to the liver for processing and storage. Then there's the renal circulation. This refers to blood flow in the kidneys. Its main role is to filter blood and to remove waste, as well as regulating blood volume and pressure. Then there's the hepatic or portal circulation. This special system derived from the digestive vessels. After the blood has picked up the nutrients from the digestive tract, it enters the SMV, again the superior mesenteric vein, then travels through the portal system, where nutrient-rich blood then travels to the liver for storage. The portal system, which originates in the mesenteric vessels, leads to the liver. And finally, the systemic circulation refers to the blood flow throughout the body except for the lungs. This breaks down into the arteries and the veins. So arteries are the circulation that carries oxygen and nutrients to the body tissues, and veins removes carbon dioxide and all the other junk from all areas and tissues. All systemic arteries branch from the aorta. All systemic veins return blood to the right atrium, which is made up of the SVC and the IVC, so the superior vena cava and the inferior vena cava. Reviewing major arteries of the systemic circulation, so the aorta, branches, and its pathology. Aorta is made up of the ascending aorta and the aortic arch. The ascending aorta travels upward from the left ventricle and branches off to form the coronary arteries to the heart. The aorta is working against gravity. Now we get into the coronary arteries of the aorta. The coronary arteries branch out from the aortic arch into three, which then further branch out from there. The first branch is the brachiocephalic trunk, which branches into the right subclavian artery and the right common carotid artery. The second branch is the common carotid artery, or the left carotid artery, and the left subclavian artery. The coronary arteries have three branches, with the first being the brachiocephalic artery, which further branches into the right subclavian artery, which feeds the axillary artery, and the right common carotid, which bifurcates into the ICA and the ECA. The ICA is the internal carotid artery, and the ECA is the external carotid artery. The second branch is the left common carotid, and that bifurcates also into the ICA and the ECA, so the internal carotid artery and the external carotid artery. The third branch is the left subclavian artery, which feeds the axillary artery. The left and right common carotid arteries are mirrored arteries. They travel into the head and then bifurcate to form the internal carotid artery and the external carotid artery. The internal carotid artery supplies the brain, and the external carotid artery supplies the face. The left and right subclavian arteries branch out and feed the axillary artery. The axillary artery supplies blood to the upper arm. A trick to remember is subclavian is Latin for under the collarbone, so subclavian, so subclavicle, so below the collarbone. And then axillary, a little trick to remember that is think of Axe body spray. Axe body spray usually is sprayed under your arms, and the axillary artery supplies blood to the upper arms. The descending aorta describes the aorta from the arch to the L4 vertebrae. So think of a candy shape. The arch extends down to the fourth lumbar vertebrae, so the L4. The aortic arch descends posteriorly along the back wall of the heart through the thoracic cavity, where it pierces the diaphragm to become the abdominal aorta. The descending aorta is called the thoracic aorta, enters the abdomen through the aortic opening of the diaphragm anterior to the 12th thoracic vertebrae and in the retroperitoneal space. So the thoracic aorta is the portion of the descending aorta that goes from the aortic arch to the diaphragm, and the abdominal aorta is the portion of the descending aorta from the diaphragm to the bifurcations of the iliac arteries. So a visual of the descending aorta is from the arch to the level of L4 vertebrae, which is here. So L4 vertebrae. And the thoracic aorta is from the arch to the diaphragm, which we see here. The abdominal aorta is from the diaphragm to the iliac, so from the diaphragm all the way down to where it bifurcates. Thoracic to abdominal aorta. The abdominal aorta extends from the diaphragm at the level of the T12 vertebrae to the lumbar vertebrae. So the T12 vertebrae to the L4 lumbar vertebrae right before the bifurcation. So from the diaphragm to the bifurcation. The abdominal aorta extends from the T12 to the L4 where it bifurcates into the right and left common iliac arteries. There are paired and unpaired branches of the aorta. So the paired branches come in twos and are mirrored, and the unpaired branches are singular and there's only one. There are 5 paired branches of the aorta, which include the suprarenal arteries, the renal arteries, the spermatic or ovarian arteries, so spermatic for males, ovarian for females, the lumbar arteries, the common iliac arteries, which further divide into the internal and external iliac arteries. The unpaired branches are the celiac artery, the SMA, so the superior mesenteric artery, and the IMA, the inferior mesenteric artery. Way to remember the unpaired branches is, if you remember the show CSI, crime scene investigation, when you're assessing a crime scene, evidence cannot be duplicated. So it is representative of the unpaired branches of the aorta. This branch of the aorta is the celiac axis, and this is in an unpaired branch. The celiac axis is also known as the celiac trunk. It extends from the anterior surface of the aorta, so it comes out of the front part of the aorta. It's about 1 to 2 centimeters below the diaphragm at about T12 to L1. It's a short stem which trifurcates, so it splits into 3. The splenic artery, the left gastric artery, and the common hepatic artery. The splenic artery is the larger branch which feeds the spleen, pancreas, and fundus of the stomach. The left gastric artery is the smallest branch and feeds the gastric or stomach. The common hepatic artery supplies the stomach, the liver, the gallbladder, and the duodenum. The common hepatic artery divides into the right and left hepatic arteries, and the hepatic artery provides 20% of blood flow to the liver, and the portal vein provides 80% of the blood flow to the liver. If you think to remember, portal equals priority, so it has the higher percentage of blood flow through the liver. Again, the first branch of the aorta, which is the celiac trunk or the celiac axis, trifurcates into 3 different arteries. The 3 different arteries being the splenic artery, the left gastric artery, and the common hepatic artery. The splenic artery is the larger branch which feeds the spleen, pancreas, and fundus of the stomach. The left gastric artery is the smallest branch and feeds the gastric or the stomach. The common hepatic artery supplies the stomach, liver, gallbladder, and duodenum. It divides into the right and left hepatic arteries, and the hepatic artery provides 20% of the blood flow to the liver. The celiac axis has branches. The first branch of the celiac axis splits into the splenic artery, the hepatic artery, and the gastroduodenal artery. Branch of the aorta is the superior mesenteric artery, or the SMA. This is an unpaired branch. It originates from the anterior surface, so front of the aorta, approximately 1 to 2 centimeters below the first branch, which is the celiac axis or the celiac trunk. It originates posterior to the neck of the pancreas and courses inferiorly. The origin of the SMA is posterior to the neck of the pancreas. The distribution of the SMA is through the small intestines, the proximal half of the ascending colon, including the cecum. The cecum is the part of the large intestine where the appendix extends, and the proximal end of the transverse colon. The third branches of the aorta are the renal arteries, which are paired. They're located at the level of L1 and split into the left renal artery and the right renal artery. The right renal artery courses transversely posterior to the IVC and the right renal vein. So it goes across and behind the IVC and the right renal vein. The left renal artery courses anteriorly and caudal, so it goes towards the front. The left renal artery is typically a little higher than the right. If you think about it and helps to remember it, you think about the liver pushing down on the right renal artery since it's a large organ. The distribution is to the right and left kidneys, adrenals, and ureters. Viewing the third branches of the aorta again, they are the renal arteries, which go into the right renal artery and the left renal artery. The right renal artery courses transversely posterior to the IVC and the right renal vein. The left renal artery courses anterior and caudal. The left renal artery is typically a little bit higher than the right. If you think about the liver is a large organ that pushes down the right renal artery. The distribution is to the right and left kidneys, the adrenals, and the ureters. Fourth branch of the aorta is the IMA, or the inferior mesenteric artery. This is an unpaired artery. It originates from the anterior wall of the aorta at about the level of L3, so it comes out of the front of the aorta. It's about 3 to 4 centimeters proximal to the bifurcation of the aorta and runs caudal to the left. Its distribution is the left portion of the transverse colon, the descending colon, the sigmoid, and the rectum. So reviewing the distribution of the IMA, or the inferior mesenteric artery, which is the fourth branch of the aorta, an unpaired branch. The distribution is from the left portion of the transverse colon to the descending colon and the sigmoid, and then the rectum. The anterior branches of the aorta consist of the celiac axis, the SMA, and the IMA. So the anterior branches of the aorta all arise from the anterior abdominal aorta. The celiac axis, that's the first major branch of the abdominal aorta. The superior mesenteric artery, or the SMA, which origin is 1 to 2 centimeters distal. The anterior mesenteric IMA, the origin is 3 to 5 centimeters proximal to the aortic bifurcation. The transducer positions for scanning the abdominal aorta are the sagittal or longitudinal view, the transverse, or the coronal. In the transverse view, arteries are circumferential or round, and veins are elliptical or oval due to being more elastic than arteries. The SMA runs parallel to the aorta, so it travels downward towards the small intestine. These are two images of the normal spectral Doppler of the abdominal aorta. The proximal abdominal aorta shows triphasic flow pattern, antegrade systolic waveform, early diastolic reversal, and low velocity antegrade flow. The middle abdominal aorta has biphasic flow pattern, antegrade systolic velocity, early diastolic reversal, and no antegrade diastolic flow. This is a transverse view of the celiac axis, or the first branch of the aorta. This is a transverse view of the proximal aorta. The renal arteries are visible, and this suggests that the image is of the proximal aorta. So the renal arteries are here. This is a sagittal view of the proximal aorta. The celiac trunk is the first branch of the aorta. The SMA runs parallel to the aorta, and this can be seen in this image. This is a transverse view of the celiac trunk, anterior to posterior measurements of the proximal aorta are being taken, and there are 3 branches of the celiac trunk visible. So the splenic artery and the common hepatic artery. In these images, we see the normal Doppler of a celiac axis. So the celiac axis, again, is the first branch of the aorta. They are high-resistant vessels, which have more branches, and low-resistant vessels have fewer branches. Here we see a normal hepatic artery waveform. This is a low-resistance spectral pattern. A couple more images of Doppler being used with high-resistance vessels. The high upstroke of the spectral Doppler indicates a high-resistance vessel. This is a normal spectral Doppler of the SMA, or the superior mesenteric artery. These are high-resistance flow, which shows high upstroke because it is a high-resistance vessel. Here we see the SMA and the right renal and left renal arteries and the IVC. The right renal artery comes down under the IVC, and the left renal vein goes from the SMA to the aorta. This image shows the IVC and the right renal vein. Here we see a normal left renal artery. We have a grayscale image and a color Doppler image of the proximal main left renal artery. The right renal arteries come off of the aorta at about 90 degrees, and we see that in this first image, which is a sagittal or longitudinal version of the aorta. The right renal artery is the only vessel to course laterally under the IVC. It often indents the IVC. Here we see a normal spectral Doppler of the inferior mesenteric artery. The IMA is usually too small to be seen on an image, but the IMA originates from the left anterior aspect of the aorta and descends along the left side with straight course in its proximal portion. Now getting into aortic pathology and arterial disease. Major pathological changes involving the aorta include ectasia, which is a general widening and dilation that appears as a tube of the aorta, losing the normal tapering. Tortuous is a general lengthening that occurs due to increased lengthening of the aorta due to the loss of elasticity. This stretches vessels that go to major organs. Aneurysmal dilation is the abnormal widening of an artery. Atheromatous, a form of arteriosclerosis in which there are localized accumulations of lipid-containing material. This is seen with advanced stage. Ultrasound demonstrates luminal irregularities called plaque, tortuosity, and wall calcifications. Atherosclerosis is an arterial disease. In advanced stage, atherosclerotic changes occur. Atherosclerotic changes can be seen in as early as 10 years of age due to a fat-leading diet. Atherosclerosis is a pathological condition in which there is a thickening or hardening of the artery and loss of elasticity of the wall of the blood vessels. This looks like any type of fat in the vessel that looks like chicken fat. This pathology can be seen on an ultrasound when a vessel demonstrates luminal irregularities, including plaque, also known as stenosis, tortuosity, and wall calcifications. Normally, when plaque develops, it has a smooth appearance, and over time it can become calcified. An atheromatous vessel has clumps of fat with irregular edges that are in danger of breaking off. As the heart pumps, the accumulations can flow down to the toes and cause a blockage, which can lead to gangrene. There are abnormal dilations due to a weakness of the vessel wall. Symptoms include palpable pulsatile abdominal masses, mid-abdominal pain, ovarian severity, and lumbar pain. Ultrasound is used extensively for the detection of abdominal aortic aneurysms. Aneurysms can be genetic, usually atherosclerotic or arteriosclerotic at origin. Usually they project from the anterior to the left midline and usually project from the left, not the right. 90% of abdominal aortic aneurysms originate below the renal arteries. Less than 4% involve the renal arteries, and aortic calcifications can be seen on the anterior, posterior, and lateral plane abdominals X-ray film. Ultrasound is the preferred modality over X-ray. There are three types of aneurysms: a fusiform aneurysm, a saccular aneurysm, and a dissecting aneurysm. There's also a pseudoaneurysm, which is a different type. One thing to remember is that it's important to distinguish and for the sonographic tech to determine if the abdominal aortic aneurysm involves the renal arteries. So the first form, the fusiform aneurysm, involves all of the walls of the aorta. The saccular is due to a weakening area on one side of the aorta. So if you think saccular section, so it's only involving one section or one side of the aorta. It does not involve the entire circumference. A dissecting aneurysm is when blood shunts between the tunica intima and the tunica media, creating two pathways for blood. This happens when there is blood pressure that is too high. A pseudoaneurysm is a hole in the intima of the vessel wall through which blood escapes, but it is contained by the deeper layers of the aorta or the adjacent tissues. So it is not a true aneurysm, therefore the pseudoaneurysm. This is a visual of the three types of aneurysms, with the fusiform aneurysm affecting all sides of the aorta. The saccular aneurysm only affecting one side of the aorta or one section of the aorta. And aneurysms can affect any part of the aorta. It can affect the beginning part where you see the widening, the descending thoracic aorta, or the abdominal aortic aneurysm, which is seen right above the bifurcation. This is a visual of what the blood flow looks like in a fusiform aneurysm and the blood flow in a saccular aneurysm. This is a visual of all the different types of aneurysms, including the pseudoaneurysm and the dissection. Again, the pseudoaneurysm is when the blood shunts between the tunica intima and the tunica media. The fusiform affects all three sides of the aorta. The saccular aneurysm affects only one side or one section of the aorta. An aortic dissection is when blood flows in between two layers of the aorta, creating a false lumen and a true lumen. A fusiform aneurysm affects the entire diameter of the aorta. This is the most common type of abdominal aortic aneurysm and is most commonly seen at the distal aorta, close to the aortic bifurcations. The ultrasound will show atherosclerosis of the vessel is as decreased pulsations of the aortic wall and with bright echoes reflecting the degree of thickening and calcification. These aneurysms are often extended into the iliac arteries. In this image, we see the fusiform aneurysm where the plaque is decreasing the lumen. We also see the bright echoes reflecting the degree of the thickening. These images show a fusiform aneurysm in the longitudinal version, so sagittal version, with measurements from the anterior wall of the aneurysm to the posterior wall of the aorta. And this view on the right here is a transverse view. We see the spine here, and the fusiform aneurysm is shown with a decreased lumen. A saccular aneurysm does not involve the entire circumference of the vessel wall. It occurs when there is a weakening on one side of the wall and often occurs due to trauma like a vehicle accident. Saccular aneurysm shows a sudden transition between normal and abnormal and is somewhat spherical and larger than a fusiform aneurysm. This type of aneurysm is connected to the vascular lumen by a mouth that varies in size. It may be partially or completely filled with mural thrombus. Pulsations within the aneurysm sac may be diminished if there is extensive thrombosis. Again, think section for saccular. Only one side of the abdominal aortic wall is affected. These are sagittal views of an abdominal aorta with a saccular aneurysm. Again, longitudinal with a saccular aortic aneurysm affecting only one side of the blood vessel. Another couple images showing saccular aortic aneurysms affecting only one side of the aorta. The aneurysm arises again from a weakness in a vessel wall and does not affect the full circumference of the artery wall. A pseudoaneurysm is a hole in a vessel wall bleeding into the tissue. So it looks like an aneurysm, but it is not. So pseudoaneurysms with color Doppler, blood can be seen to flow into a protuberance during systole, so during heart contraction, and out during diastole, which is when a heart relaxes. These events occur after trauma to a vessel due to a traumatic accident or surgery after an interventional cardiac catheterization or angiography procedure. The differences between an aneurysm and a pseudoaneurysm is that blood escapes through a hole in the intima, the tunica intima. So this is an aneurysm. Blood escapes through a hole in the tunica intima of the vessel wall, but is contained by the deeper layers of the aorta. So there are two lumen creating an aneurysm. The pseudoaneurysm does not have two lumen, and the blood just flows back in. The yin-yang sign describes a characteristic swirling pattern that is seen within a pseudoaneurysm on color Doppler ultrasound. Visualizing both colors swirling together within the pseudoaneurysm sac indicate the complex multidirectional flow. The pulse wave Doppler within the pseudoaneurysm will demonstrate a to and fro or bidirectional waveform, further confirming the swirling flow pattern. Evaluation of the aorta. An evaluation of the aorta has several steps. The first being evaluating the extent of the aneurysm. Does it include the renal or distal aorta to the iliacs? If the distance from the renal is 3 to 4 centimeters, the renals are not usually involved. Second step is to determine the size, so measure in a transverse plane at its greatest dimension. The measurement should be taken from the outer wall to the outer wall. Comparison to the normal aortic measurement. So a normal aortic measurement is up to 3 centimeters. Anything greater than 3 centimeters is considered an aneurysm. A measurement from the inner lumen to the outer lumen should be recorded. And thrombus. Irregularities of flow increase the likelihood of a clot formation. An ultrasound demonstrates low-level echoes within the aortic lumen. As the vessel starts to get clotted off, it reduces blood flow to the extremities. Aortic rupture presents with specific patient symptoms. A patient that has an aortic rupture will present with severe abdominal pain radiating to the back. They will be pulsatile due to the hemorrhaging causing blood to go into the retroperitoneal space. Aneurysms less than 5 centimeters rarely rupture. Over 3 centimeters, the patient should be evaluated every 3 to 6 months. And then once a year passes without occurrence, the scans can be reduced to yearly. Over 7 centimeters, ruptures are more frequent. Patients usually are evaluated every 3 to 6 months. If a patient experiences sudden loss of pain, this could indicate a possible rupture, which can be fatal. Guidelines for aortic measurement. A normal measurement would be up to 3 centimeters. An abnormal measurement is considered if an aneurysm is more than 3 centimeters and is usually evaluated every 3 to 6 months. Surgical intervention usually occurs if an aneurysm is bigger than 6 centimeters. It must be treated with surgical intervention. One way to repair an aneurysm is with a stent, and stents are a less invasive approach to repairing an aneurysm that includes a graft that is placed through a small incision in the abdomen. Form of aneurysm repair are grafts. Grafts are abdominal cut downs An abdominal aortic aneurysm may be surgically repaired with a flexible graft material attached to the end of the remaining aorta. The graft may be anastomosed or surgically unified, connected, in an end-to-end manner or an end-to-side manner. These grafts would be placed within the aorta at the level of the aorta and iliac artery or within the femoral artery. Synthetic material used for graft produces bright textured echo reflections compared with those from typical aortic walls. It's important to distinguish, again, if the aneurysm is involving the renal arteries.